number of positive notes. So with that happy note, when all are positive, I will stop and say thank you.
Thank you, Mr. Chairman, for the kind introduction. And I would like to thank the organizing committee for inviting me to give this lecture. I have to admit it's a very broad topic that needs to be covered and might be encroaching on other subspecialties such as ONG, infertility, endocrine, fetal-maternal, radiology. So just to name a few. And being a clinician, I would like to present this topic from the clinician point of view, unlike most textbooks which tend to cover topic from head to toe. Right. Previously, as we know, many tools for our clinical management has been using various medical conditions has been invasive with all various risks, not only to the patient but also to the medical personnel involved in the management. But with several additions to our armamentarium of medical practice, many methods of diagnosis and treatment has become less invasive, making it safe both for the patients as well as the medical personnel involved in the management. And of these, imaging techniques has played the greatest role in our daily medical practice. For the ONG specialists, especially imaging, namely ultrasound, has become like a third hand for most of them. So much so that some of them are not examining patients anymore at the antenatal clinic. Every patient that come in, they put in straight on the scan. And this is quite worrying, especially for the new registrars that's training. Everything seems to be based on ultrasound. Now, in the field of reproductive endocrinology, imaging plays an even more important role for diagnosis, treatment, monitoring, and avoiding disasters, timing of intervention, predicting the future outcome, avoiding major and unwanted surgeries, and for training as well as for research. Now, for successful reproduction, you require an intact hypothalamo-pituitary gonadal axis. And for the female, you need to have a receptacle, namely the vagina for the deposition of sperm, and an intact uterus for the baby to grow inside. So any of these things can go wrong, and this can easily be diagnosed with the use of our various methods of imaging techniques. Now, and these are the conditions that we tend to use a lot of imaging, using PCOS, for example, tubal patency, congenital uterine abnormality, endometriosis, uterine fibroid, adenomyosis, and pituitary adenoma, just to name a few. In the diagnosis of PCOS, for example, in clinical endocrinology, most people still have controversies in diagnosing the condition. Even across the Atlantic, the Americans and the Europeans have differing ideas about who should be considered as polycystic ovarian syndrome. Some of them based on clinical, some based on hormones, some based on biochemical. And the reason why there's difficulty in diagnosing these conditions is because it depends on when the patient presents to us, because it is a spectrum. It can present as early, where's the pointer? Is it here, the pointer? Okay, never mind. So it can be either in the early part, where it can be the present as a teen lady with BMI of less than 25, with an LH of 1, still having polycystic ovarian syndrome, or it can be present as a midpoint, where you have the BMI of 25 to 30, LH increasing to 2, still with polycystic ovaries, or it can go to the other extreme, where they are very obese, BMI of 30, LH of FSH, LH of 3, with massive polycystic ovarian syndrome. So it depends on where they present to you, depends on the spectrum. Now, in the age-old technique, we tend to present diagnosis condition based on our laparoscopy, where you can see the pearly white ovaries, very shiny, and there's no rugae like a typical ovary, and sometimes very enlarged because of all the antral follicle that's not ruptured. But now, but I know that it's a very invasive procedure with all its anesthetic and surgical risk. And we try to differ from doing now in gynecology. And what we do now is to diagnose them based on the ultrasound, where if you see this typical pearl necklace feature of the ovary, this indicates that this patient is having polycystic ovarian syndrome. And the reason why this is important, because the minute you diagnose their polycystic ovarian syndrome, they do not need to go for the surgery. They can just go for medical treatment first, and unless that fails, the next step will be surgery, where we do ovarian drilling for this type of ovaries. For tubal patency test, there are several tests available, which is the hysterosalpingogram, this is HO, and you can know that there's a blatant exposure for the medical personnel. I remember when I was in my young days of training, I have to do my own injection of the dye, and you're exposed to the X-ray. And you can do diagnostic laparoscopy. Again, here is a very invasive, like I said just now, with all the risk. Or you can do the gas insufflation test. It's an old technique, but if you have a positive test, you don't know which side is blocked, because it just shows that the sound comes out to the bubbles, and there's a risk of air embolism. You can use also your laparoscopy, which is very invasive, like I said just now, but the best now is using the tubal pregnancy test using the high COC test. It's a highly concentrated dextrose solution which you inject into the uterus, and we watch for the bubbles presenting at both ends of the fallopian tube. It's a very non-invasive procedure. It can be repeatable, but the only problem is until now, it has not been taken up by the gynae world. I don't know, for one reason or another. Now, hydrosalpinx need to be diagnosed early, because you know that it's usually due to PID and affect the result of most fertility treatment because of the hostile environment that they produce in the uterus, leading to poor fertilization, poor implantation, high cancellation rate, and high miscarriage rate due to the high level of prostaglandin, inflammatory cells, and the pathogenic agents present inside the peritoneal cavity. And this can be diagnosed using a simple hysterosalpingogram or an ultrasound, or the bigger ones can be diagnosed with CT scan or MRI if they are more than 2 centimeters big in diameter. But with the use of, just to emphasize the importance why we need to diagnose hydrosalpinx, this is a typical picture of what we do a transvaginal scan. You can see the straight structures of hydrosalpinx, and those are the follicles where we need to collect the eggs from, and that's your iliac vessels. You can imagine how easy for us to puncture this hydrosalpinx before even entering the follicle. And whenever you contaminate the needle, the chances of fertilization rate and cleavage rate is going to be very poor in such treatment. So you need to diagnose this condition early. And to stress another point, this lady had to be cancelled the cycle because of the drainage of fluid from the hydrosalpinx into the uterine cavity just before embryo transfer. And you can see the fluid collecting from the hydrosalpinx in the uterine cavity. So you can see how important it is to diagnose hydrosalpinx before you start patients on fertility treatment. But once the diagnosis has been made, we need to be proactive about it. What we need to do, we got to cover the patient with antibiotics. We can drain the fluid against by transvaginal scan. And more important, we can clip the tubes on both sides. And according to Strandl, this will improve your fertilization rate as well as cleavage rate, remarkably with good result in your IVF treatment. So we need to diagnose that early before we start the treatment. Many uterine abnormalities can be diagnosed using the ultrasound, simple ultrasound. So many is there, I can list down there. And you can list it. You can also diagnose it by using HSG, like I said, it was invasive, or diagnostic laparoscopy. Or you can use MRI or CT scan, which is expensive but not readily available in most hospitals in the third world countries. You can use a simple HSG, like I said, now you can see the septate uterus. You can see a biconate uterus. Using the MRI, you can see also the presence of hypoplasia of the uterus, very small uterus. So you can know that patients have difficulty to conceive. And a single horn of the uterus, what you call uniconate uterus. But even a simple scan can do that. As you can see in good hands, you can diagnose biconate uterus. You can see the 2 horns of the uterus, uterine diadelphi, uterine hypoplasia, absence of uterus in the case of Loki-Gansky syndrome. And this method is very non-invasive, non-repeatable, and very inexpensive. In the good hands of the ultrasonographer, this should be able to be done without going to go for all these expensive tests. Endometriosis has also been shown to affect your fertility treatment because I couldn't abandon it at all. And it's easy to diagnose the big ones by your scan based on the consistency or the hazy consistency of the content of the cyst. The only problem is to diagnose the small early stage endometriosis, which are just points. You can see there, dots you can see, and then you can only be seen by laparoscopy. And to do that, the patient got to undergo the risk of surgery and anesthesia. But we do know that there is collection of fluid in the pouch of Douglas immediately when the menses have stopped. And we can use as a basis to diagnose endometriosis, whereby simple ultrasound, you can actually see the fluid collecting in the peritoneum, even present after 14 days after the menses. And we combine this with your clinical symptoms, ultrasound evidence, and the race CA125. You can start the patient straight away on treatment without even to undergo the laparoscopy test just now. You can even diagnose infected endometriotic cyst, where you can see there's pus present inside by the haziness of the cyst that's contained inside the endometriotic cyst. In terms of infertility, where fibroid is concerned, it's only the submucous and the intramural fibroid that will be of concern for us, because that will affect the implantation of the embryos inside the uterus. And unless the subserous fibroid is too big, this need also to be removed. So any patient who has been diagnosed with these fibroids by ultrasound need to have it removed before they undergo the fertility treatment. But from the point of view of the clinicians, the problem is trying to diagnose adenomyosis, because most of the time we diagnose this condition only intraoperatively, and that really poses a problem because the patient may be under, they can't get the consent, because we know that a patient, if they don't diagnose their fibroid, myomectomy will be the answer, but if you're having adenomyosis, you need to go for hysterectomy. So you get to differentiate this problem before you go for the op. Now, by a simple scan, you can actually differentiate these two by looking at the site, where is what present as compared to fibroid, the consistency, the poor demarcation of the mass as compared to fibroid, and the distribution of blood supply. But you need to be very good in ultrasound to diagnose this condition. But even better choice, this is another one just to show the diffuseness of the adenomyosis in the uterus. But the better choice to use would be your Doppler ultrasound, where you can actually see that there's a lot of vessels passing through. This best done about day 12, just before the menses. We can actually see all these vessels dilated within the adenomyosis as compared to fibroids, where the vessels are mostly at the peripheries. Endometrial thickness has also been shown to affect the success of your fertility treatment, according to Kovacs et al. So in any fertility treatment, we try to monitor the timing of the procedure or even for cancellation cycle based on the endometrial thickness. So we do normally a trial run for some patients, right, where the acceptable thickness is between 10 to 12 millimeter. That would be the good one. And this should be around the ovulation time or around the embryo transfer. A thin endometrium could be due to three things. It could be because it's hypoplasia from the beginning, because they're inborn with it, or it could be inadequate estrogen stimulation from the follicles that you stimulate, or because of the anti-estrogen effect of some treatments, especially clomiphene. It's a good clomiphene, it's a good follicular development for follicles, but it's an anti-estrogen. And the side effect is that it causes a thin endometrium for those susceptible patients and a thickened cervical mucus, making it difficult for the sperm to swim through. Thus, during fertility treatment with clomiphene, we tend to monitor this endometrial thickness to decide whether to go on ahead with the treatment or not. Just to show you the various thickness of endometrium, you can see here is very thin, only 6 millimeter. 8 millimeter is a bit thicker, but still not useful for us. A good one, 12 millimeter. That's too thick. Even too thick is not good because the uterus got to support. The vessels to support the endometrium can be a bit difficult. They tend to abort later on. So once the diagnosis of thin endometrium has been made with clomiphene treatment, we can revert to other medications, such as letrozole, which is used for our breast. We can use injection of hormone-menopausal gonadotropin or follicular-stimulating hormone. And if the endometrium still remains thin, then the problem is actually inborn. And I can bet my bottom dollar for this patient, whatever ART treatment you make the patient undergo, the result will still be very poor. This is a first-time couple who came to me where the male has gynecomastia, galacturia, and azoospermia. And he's a taxi driver in the middle of Kuala Lumpur. And we check the, we call this a visual field test. You find he has a being right temporal hemianopia. Now you can imagine he's driving in KL as a taxi driver. It's quite a wonder why he doesn't have any accident up till now. And we did the CT scan. It shows there's a huge microadenoma blocking on the optic chiasma, and that's causing him to have all these symptoms that he's having, including azoospermia. And this, the main reason why we need to diagnose between the two is whether to go for medical treatment or you're going to go for surgical treatment. This guy went for the transsphenoidal treatment, and that makes him able to have a child later on. I think it's about 4 children already by now, because his sperm count returns back to normal. And you can diagnose a lot of other conditions, intracranial, associated with infertility, especially empty cellular syndrome, hypoplasia of the pituitary, aplasia, or even craniopharyngioma. That includes even endometriotic cysts, however thick it is, we can actually dilute them. And we can also inject these patients with alcohol, 90% alcohol, into the cysts, and this will prevent it from coming back again. And all this can be done under ultrasound guidance. And more important is for picking up eggs in the case of infertility treatment, IVF treatment, where we need to directly visualize the follicles where the needle is supposed to be in, especially to try to avoid all the pelvic organs within the vagina, within the pelvic cavity. So you have got to ensure that the needle is in the follicle. You have to aspirate all the follicles completely to avoid ovarian hyperstimulation later on. And this also to avoid the injury to the surrounding organs. Now you must remember this Even though you look at simple procedures, there's a lot of research using 30 cm long, sharp dribble needle entering pelvic cavity. There's so many vital organs. You've got the bladder, ureter, bowel, iliac vessels, and just to emphasize how near, you can see the focus here, and there's a bladder, and this is just 1.5 millimeter, so near. And that's when you iliac artery. At one point, at one glance, it looks like it's a follicle. You might accidentally puncture that. But if you turn the probe 90 degrees, you find it's actually a long vessel, actually. So you might have punctured it by accident. So then look at the distance. It's very close, just 2 millimeter. And you have here the bowel. You can see that's how near the bowel is. It's just moving around everywhere around and just beside the ovarian follicle. And when we puncture this vessel to pick up the eggs, you can easily puncture the bowel if it's not done in a proper manner. And even more important is when embryo transfer time. The success in ART depends on what site where the embryo is placed. And also ensuring that there's no trauma to the upon entrance of the embryo into the cervical canal, because any bleeding will affect the result. And you need to directly visualize where you place the embryos, because they say that the best result is to place the embryo exactly about 1 cm just below the fundus. And this is best done under ultrasound guidance according to school.